Hello and welcome to the Myeloma Minutes, a podcast for patients about multiple myeloma. My name is Jamal Qatari. I'm a consultant haematologist based in Oxford in the United Kingdom, and I'm here with my co-host
Sally Moore. I'm a consultant haematologist. I too work in the UK and I'm based in Bristol.
Sally, this is the start of a journey into myeloma, all aspects of it for patients, from diagnosis to treatment to new therapies that are coming along, alternative ways of thinking about diseases that haven't quite become myeloma. And the field has exploded. We're both feeling quite inspired and we're recording our first podcast. We both spent 2 days at the Oxford Myeloma Workshop, which has been a brilliant 2 days, full of clinicians, brilliant talks, patient interaction. And I think we're delighted to be talking about this because we've been thinking about doing this for a while. Sal, why don't you introduce yourself and give our listeners a bit of information about yourself, how long you've been a consultant, things that you're particularly interested in, and then maybe I'll do the same.
Yeah, thanks, Jam. I mean, we've spoken about this for a long time, haven't we? I think we're entering that whole new frontier, really, of exploring myeloma and what it means to patients and their families and their relatives. And we're delighted for all you listeners joining us on this journey, really. I think it's fair to say we're both feeling a little bit nervous here today.
Yeah, a little bit, for sure. Yeah, I mean, we're okay sometimes, sitting, giving a talk in front of 100 clinicians, but talking to our patients on this new medium is a really exciting, slightly nerve-wracking.
Oh my God.
And I think we're both really excited to sort of be sharing this journey with you.
Yeah, absolutely. But to answer your question then about myself, so I'm a doctor. I've worked as a medic now, goodness, I mean, I've got grey hairs to show for it, but for some time as a consultant in Bath in the UK and then Oxford with you and now in Bristol. And I specialise in the field of myeloma well over a decade ago now. And it's a really exciting area of medicine, I think, to explore and a real privilege to really be working in this field when it's exploding in terms of its developments, but also the privilege of working with patients and their families and all that you learn from them as you go along the journey and you learn together, really. So my work involves day-to-day clinical practice, and then a significant chunk of my work is all about clinical trials, and hopefully they enable the future of myeloma to sort of grow and develop and new therapeutics coming to the market, as well as dabbling in a little bit of research, which is obviously also very important myself, sort of research I want to undertake to answer questions that I'm interested in, again, to contribute to the body of knowledge. So that's a tiny bit about me. But as we go through these weeks of recording, I suspect I might drop in a few more bits and bobs.
Sal, but you're also part of the UK MRA, right? So
yes.
you're involved nationally. So tell us a little bit about that as well.
Yeah. So I do forget to mention things. It's a terrible tick of mine. So yeah, UK MRA is a myeloma sort of research association or forum in the UK. And I'm a member of that. And we sort of get together, myself and myeloma clinicians in the UK, to discuss areas of particular interest, questions that we want to be answered about myeloma and about the patient population, and again, hopefully, broaden the body of knowledge. So yeah, one of the many extra bits and bobs we do as part of our job, as you do, Jam. So yeah, what about you?
Yeah, so I've been a consultant haematologist for about 10 years now, but we go back a good 15 plus years.
Yeah.
So me and Sally trained together at UCLH in London. We did our part 2 exams together, lots of revision and looking at blood films under microscopes and working out all sorts of things about thrombosis and transfusion and all the brilliantly interesting things about haematology. But just like you, I focus on myeloma and associated disorders. I've also treated a reasonable amount of lymphoma in the last few years as well. But my main area of interest and clinical research activity is within myeloma. Very lucky to be working here in Oxford. We have brilliant links with the university and industry collaborators, meaning that we're extremely active in clinical research. But as you say, I think it's a privilege to work in this field because the Oxford Myeloma Workshop is really front of my mind. I was quite taken actually by something that, so there was an eminent myeloma clinician from Boston, Paul Richardson, there this morning, who gave an absolute tour de force on the treatment of myeloma. It's those little stories that resonate. And he said he remembered the first myeloma patient he ever treated. Do you remember? He said it was 1986 and she was a matriarch from Hackney. I don't know why I remember his exact words, but he actually talked about it very, very movingly in a way. It's like, I remember her very clearly. I admitted her in March, and then 3 months later I signed her death certificate. I mean, there was basically very little treatment you could give, and prognosis was appalling. But over the last 2 days, we've seen, haven't we, how that has changed significantly. With our patients, living for many years. And part of what we've been talking about over the last couple of years, isn't it, is that we want there to be really good information and a resource for patients that is a living library of information about where the field is changing, but also information for people who maybe have just been diagnosed. So what sort of topics, Sally, are we going to look at over the next few episodes, seasons, year? Am I getting over? Maybe I'm getting a bit optimistic. Season 1. What are we going to be talking about?
Dear me, is there going to be a cliffhanger?
Well,
at the end of it?
I'm going to release it all at once, or just do weekly episodes. Who knows? We'll find out. Yeah.
I mean, I don't want to over-exaggerate this. I think there are still enormous challenges within this field of medicine, but I think it is real. Myeloma is a brilliant example of how, when you have that collaboration between academia, scientists, clinicians coming together, what can be achieved within that field. And of course, let's not forget the most important individual in that room that I failed to mention, which is the patients, and how they live with their condition and what we learn from them in day-to-day clinical practice. So, yeah, what is going to happen in the next decade or two? What are we going to cover in this podcast? What are we hopefully going to talk about that we aren't even cited on yet because the developments are so thick and fast? But I hope that we cover toxicities of treatment, because it's really important. I hope we address and we cover questions that often individuals coming to clinic perhaps don't feel they can ask their team around them, or they don't have time, or they forget. But as well as toxicities of treatment, how well the treatments work, what to look out for in terms of living with myeloma and how to minimise complications, to talk about some of the investigations we do, for example, and also really to gain a little bit of understanding as to where the field might be going in the future as well. So I think that's just a start of a 10, but I think that you and I have talked together and we could natter away for hours about this. So watch out. There could be quite a lot of content.
Yeah, no, put the kettle on. Absolutely. We're going to do some sort of nuts and bolts, aren't we? So we'll be talking about, the basics. What is a paraprotein? I've been told I have a protein in my blood. What does that even mean? How we describe myeloma. And we'll have guests when we want to talk about specific areas. Yeah. So we'll be doing a podcast on what sort of scans do you need in myeloma, and we'll be bringing in a consultant radiologist to talk us through all the different modalities. Other examples, symptom control is so important, so we'll be getting a colleague from palliative care and supportive medicine to come and talk about the different ways in which we approach pain. We're going to talk about research in detail. What is it to actually be on a clinical trial? What does that actually mean? But as you say as well, we're going to go into all the different therapies. And I think as the year goes on, and hopefully years go on, as meetings come and go, the big meetings where new research is presented and discussed, hopefully we'll be able to offer, bite-sized, digestible information. It's like, this research showed this, but what does that mean for me right now? And what might it mean for me in 1 year or 3 years or 5 years time? So I think the amount we will be able to talk about is huge. And I hope that people find it interesting and engaging. I think we both understand that it's a serious topic in of course, so many ways, but we will, where we can, be keeping it light and hopefully optimistic. But when they're difficult topics, we will delve into them. Yeah. And we talked about patient stories, Sally, didn't we? Yeah. We want to hopefully get some patients on the podcast.
Absolutely. Not to shirk away, really, from those difficult subjects. And they're often the elephant in the room, aren't they? The question which is sort of left unanswered and often put to the back in the interest of time. So I think, let's tackle that head on. And as we hopefully take our listeners with us, I hope we develop a relationship whereby people can ask us questions and we can then answer them in turn to the best of our ability, but we don't have all the answers. And so that's where the guests that you've just referred to will be proved to be so incredibly important to also improve our knowledge and our understanding as we go through this process. So
absolutely.
Yeah.
And what we'd say is, please also tell us, what topics do you want covering? There may be some things that we should cover sooner rather than later. As new medications get approved by NICE, we will pretty much in real time try to do an update on that drug, who can get it, what what it means and do a whole deep dive on that. But for listeners, wherever you may be, there are, of course, universal topics, irrespective of where you are in the world, and we'd like to cover those.
Absolutely, I agree. This is a condition which affects hundreds of thousands of people all over the world. So look forward to hearing from you all in due course. And just before we move on, I too remember my first patient. I don't know if you do, but I remember as a medical student sat there in a haematology clinic and a lady coming in and the consultant telling me before she arrived how her arm had broken when she picked up a cup of tea. And it always stuck in my mind. And sometimes these stories are incredibly powerful. And I often reflect on the fact it's interesting that I'm now working in this field.
Yeah.
Was there something there about that experience that really anchored in my mind and drove me forward? I don't know. But it's powerful.
I mean, I certainly have a good memory of what it was like treating myeloma 20 years ago, when I sort of just had qualified. Didn't have a lot of myeloma expertise then, but certainly remember people talking about the sadness and the limited things that we could do. So now is much more a time of optimism. But as you say, there are still huge unmet needs and areas that we need to improve in. But I think the field is moving in a very exciting direction. So as we look to the future, Sally, I'm going to ask you some difficult questions and you can ask me the same back. So in terms of where the field is going, we get asked this in myeloma now. It's like you say it's treatable but not curable. That's something that you can find anywhere on the internet, and a lot of clinicians use that as a way of talking about it. But actually, we heard in this meeting, some people find that a very unhelpful way of describing it. Is it curable now? Are there some patients that can be cured from myeloma with the tools that we have? Or is that an aspiration for 2050, 2030?
Oh, my word.
Sorry, start with a nice easy one there.
I mean,
Sal.
lay down the gauntlet. Honestly.
Please don't ask me anything.
Yeah, exactly. Just wait, Chad. Revenge is sweet. I mean, this is a really complex area. And I think to simplify it, and I think that's hopefully what we'll do during this podcast, is I think we have to look at what we think about cure. What actually is cure? Is it living with myeloma? But at the end of your life, myeloma is not the final event?
Yeah.
Or is it being free from myeloma? And if so, what does that look like and for how long? I think it's hugely variable. But suffice to say, there are some treatments which you can now offer a proportion of our patients which can keep their disease under control for many, many years. And hopefully during that time, they'll be maintaining a very good, healthy quality of life, which hopefully will be similar to that they would have enjoyed had they not had myeloma. So I think that is definitely within reach for some patients. And the ambition is, I guess, as the newer treatments, which are much more nuanced, much more targeted and effective, come through, there'll be more patients sort of falling into that group who are living for longer, living well, living with myeloma, but not, to be brutal, dying from it. So I think cure we always used to whisper about it, didn't we? Do you think we'll ever cure it? It's like it was this you almost daren't talk about it, whereas now we do openly and freely, because I do think it is potentially a realistic proposition. But I don't know, do you agree with that? This is still quite a contentious area, or would you challenge me on that and think I've overstepped the mark there?
I think what we want to give is realistic information to our patients. I think it's really wrong to be too optimistic, and then because maybe we haven't collated as much information as we could about their myeloma, we're a bit too vague. Because actually I think there is information now which allows us to be a little bit more precise. And I mean, what I tend to say is that, we think there is a emerging group of people who are living more than 10 years. And I think you're in that group. Or for people who perhaps have a slightly worse prognosis, and we're going to have a whole pod on risk and high risk disease and other things. Unfortunately, things are not so good. But when you're just starting out on your journey, you're using treatments that are available in 2025, and we know now with some of the longer follow-up of some treatments that, as you say, many patients are in remission for a number of years. So it's like you can't read the future, and you have to kind of try and read the future with information from the past.
And isn't that challenging? Because you can't sort of, one's tempted to predict, but you don't want to be over optimistic because you can only go on what's gone before. But you know that as the field evolves so rapidly that actually as the new drugs come through, the rules change all the time. It's such a dynamic process. But trying to explain that particularly as you described during the first or second visit, it's just a lot to take in. And so I really hope through this process we'll be able to illuminate and shed a little bit of light on those unanswered questions, those queries which can be quite baffling and quite confusing.
Yeah, I mean, I have to say what I do say now for some of my older patients, 80s plus, we know that they have quite genetically stable disease and they're in very deep remissions. I do tell them, it's like, genuinely, I don't think that the effects of myeloma progressing is going to be a life-limiting issue. I'm worried that you may get a toxicity and die of treatment in remission, which is clearly a terrible thing for a patient and their family, and for a cancer oncologist or a hematologist. A death in remission from toxicity is always such a terrible thing,
but fortunately quite rare.
Absolutely.
Thank goodness. Yeah,
and so those conversations I'm starting to have. So actually, rediscussing the risk benefits. Like, I think your myeloma is well controlled. I think, hopefully you'll have your 100th birthday and then have a heart attack when you're 105. But myeloma won't be the reason for it.
So here we go. The starting gun has been fired. In terms of what you're most excited about, Jam, what would that be?
I think we're all excited about the drugs and the way in which we're really getting a much deeper understanding of how the immune system is an absolutely crucial cog in the way myeloma starts, how certain treatments might work or not work. And I think, some brilliant science has been done in the last few years, and we've just been listening to so much of it over the last couple of days. And with that are all these therapies that harness our immune system to enable myeloma to go into long remissions. So I'm really excited about the cellular therapies. So whether it's CAR T therapy, newer types of antibody treatments. Every December, isn't it? It's ASH, where all the big updates often happen from myeloma trials, and just seeing how these drugs are now sort of moving towards the front line and seeing some really sort of spectacular results. Now, these are just trials, but I think the anticipation of cellular therapies, given for hopefully defined periods of times with limited toxicity, meaning that the way in which we treat is, potentially going to fundamentally change, but with ever improving outcomes. So that's the excitement from, I think, how therapy might change. But I know, Sal, you've been very much involved with really trying to make sure that the patient experience of drugs and toxicities is fully understood and really documented properly, and people are given time to discuss all of these things because people are on treatment for so long. And I know you're very interested in how that area of our field might change. Do you want to just expand on that a little bit?
Yeah, goodness, this is a huge area, and I really hope that this stands as its own specialist area and comes to the fore in the future. And I really think it will, partly because, thank goodness, people are now living with this condition for so much longer. But as you live with it, as one lives with it, I think it's incredibly important to live well with it. Otherwise, we don't want to render people in chronic pain or disability. And so placing that patient voice centre stage to try and understand what living well looks like for that person and their families, I think is incredibly important. And there's really interesting data out there looking at actually how our priorities might change perhaps as we move through life. When we're younger, we might prioritise the fact that we need to work to provide for our families or looking after our families. And when we're older, there's some evidence suggesting that people may prioritise quality of life over quantity of life. And so appreciating how that can be such a dynamic situation, how it might shift, I really think warrants attention so that we can make sure we are doing the right thing by our patients. We are properly listening to them and taking on board what their wants, wishes, needs, hopes and desires for the future might be. It's a really interesting area, particularly as we're on the cusp of big data in myeloma. There's so much data that we can collect from our patients about how they're feeling, what side effects they're getting, how that may or may not reflect how well they're responding, how to overcome weaknesses or frailty to optimise, hopefully, their quality of life. And then sort of building that into how well they're responding to treatments so that we can then learn from that. And so that when we're talking to people in the future, we can perhaps better inform them as to the side effects, of the treatment and what that might mean for them. So I think it's the very beginning of a really exciting area where I really hope the patient is also in charge, and their families, I should say.
Absolutely. And we'll be spending a good few pods talking about, I think, this area in some detail. And I think we all want to move to a place where when we go to a meeting, when a study is being discussed, it feels like there is an appropriate amount of time spent actually talking about that in a meaningful way, as opposed to, I need to put a quality of life slide in.
Yeah, I totally agree.
Which is the way it's been for quite a while. So I think we're going to be quite busy.
We are going to be quite busy. And actually, for you listeners there as well, can you just forgive us in advance for any acronyms we use? Medicine is full of it. So, we may talk in tongue or in jargon.
Yeah.
Call us out on it. It's incredibly important.
Yeah, no, it does. It does happen quite a lot. But I hope you find the next few hours of podcasts engaging and interesting and help you make sense of wherever you are in the stage of your myeloma or your loved one or your friend. I think there will be certain episodes as well which will be very much a useful adjunct to your ongoing clinical care. And what we will be doing after looking at certain topics is summarising what we've talked about as a sort of short series of questions of sort of things to ask your myeloma doctor. And of course, in lots of the time, you will be getting great care wherever you are. And we know that the care certainly, in England and in the networks of people we know is very, very good. But I think having information is powerful, and I hope that we provide a useful, entertaining resource which can make your journey easier.
Yeah, a quiz at the end of every podcast.
A quiz. Don't ask me any questions, please. But yeah, a quiz at the end of every podcast. Absolutely.
Great.
This was the Myeloma Minutes. This was our first ever episode. Thank you for joining us, and we look forward to seeing you for the next visit.
Farewell.